Dr. Janvi?
Yes, sir.
I think Professor Rasi has to join and Professor Mustafa has to join. Sir, we are having YouTube live as well as the Zoom, both are there. Can we start our program?
So you want me to share the screen?
Yes, sir. Just one sec, sir. I'll just finish a brief introduction. Good evening, everybody. On behalf of Isfaro, I welcome you all. We had successfully completed a facial trauma, reconstructive, and rhinoplasty webinar series with tremendous response. Now we welcome you all for the fifth and concluding session for the Craniofacial webinar series. Today we are happy to have most renowned person in the field of cleft surgery as our speakers. Dr. Srinivasa Gosla Reddy, sir, is from India and he is a past president, Indian Society of Cleft Lip, Palate and Craniofacial Anomalies. Dr. Nasir Najmat, he is from Belgium, professor and the coordinating program director for the oral and maxillofacial surgery at University of Antwerp, Belgium. Dr. Teng Cheng Lu from Taiwan. She is working as an attending surgeon in Craniofacial Center, Chang'an Memorial Hospital, Taipei. Professor Rase from Austria is a renowned maxillofacial surgeon and with a special interest in condyles. And Dr. Mustafa, Professor Mustafa, he is a director of Kanchur Institute of Craniofacial Anomalies. We have moderators, Dr. Rajesh Yadav, our president-elect, Isfaro, Dr. Mohan Jagde, Vice President, Isfaro, Dr. Rasu Mittal, and Dr. Gaurav Gupta, Dr. Janavi, consultant ENT surgeon. Over to Dr. Janavi for introduction of Professor Reddy.
Good evening, everyone. Welcome aboard. So I'll introduce the first speaker, that is Dr. Srinivas Gosla Reddy. Professor Dr. Srinivas Gosla Reddy is a dually qualified craniofacial surgeon who has performed more than 30,000 craniomaxillofacial surgeries. Professor Reddy is the founder and director of the GSR Institute of Craniofacial Surgery, Hyderabad, visiting professor in AIMS, Rishikesh, Yenipoya University, Karnataka, KLE University, Karnataka, Manipal Academy of Higher Education, Karnataka, Kaloji Narayan Rao University of Health Sciences, Telangana, and Krishna Institute of Medical Sciences, Karad. He is the past president, Indian Society of Cleft Lip, Palate, and Craniofacial Anomalies. He's done his MBBS from NTR University of Health Sciences, Vijayawada, Andhra Pradesh, BDS from Gulbarga University, Gulbarga, Karnataka, MDS from Mangalore University, Mangalore, Doctor of Philosophy, Radboud University, Nijmegen, the Netherlands, Fellow of Dental Surgery, RCS, England, Edinburgh and Glasgow, Fellow of Surgery, Edinburgh. Welcome, sir. Over to you.
You have to unmute your mic, sir. Dr. Reddy, you have to unmute your.
Yes, I'm trying. Yeah. Is it fine?
Yeah, it's fine.
Okay. The screen is well seen?
Yes, well
Yeah.
seen.
Very good afternoon, ladies and gentlemen. I take this opportunity to thank for giving this chance to present our work. I would say it's more of an ideology. I've been asked to speak on craniofacial clefts and their repair and our ideology. I am from Hyderabad, where we run a center called GSR Institute of Facial Plastic Surgery, where we have documented more than 25,000 cleft and craniofacial procedures from last 20 years onwards. Now, diagnosis of craniofacial anomalies should place on more emphasis on how to plan a treatment protocol. This presentation will therefore place emphasis on balance and imbalance rather than syndromes or any other such terminology. When you look at these beautiful faces, yes, they are really beautiful, but irrespective of the ethnicity of an individual, facial balance and not the facial symmetry dictates our perception of beauty. At the same time, when you look at these congenital deformities of the face, when you look at it, this deformity could be affecting the eyes, ears, nose, lips, all the facial skeleton as it is. What you see here is that they have a proper symmetry. The facial symmetry is normal, but the facial balance is imbalanced. So when I really look at these anomalies, I can always correlate it with a pentacle problem, that is the problem of eyes, ear, nose, lips, and facial skeleton, and where this imbalance can be noticed very effectively. So how do we diagnose these craniofacial clefts? So to coming to our ideology, we have proposed a classification. We call it as Seiler's morphological classification, where we have two steps. In the step one, we do the identification of the defect. In the step two, we put it into the classification. So how do we identify this defect? So we have proposed these three rings, where in these three rings, we call it as a deformity that is evident on the appearance. It could be on any of the zones of the face, or the deformity evident on examination, or deformity evident on investigation. So based upon that, we are able to identify what are the units, subunits that are affected in this deformity. So once we are able to identify the defect, then we say that is it a congenital or acquired defect? Then it could be easily put into a saying that it's a soft tissue anomaly only, or a hard tissue anomaly, or a combination of hard and soft tissue anomaly. So all we need to identify is where exactly is this defect is, and then what sort of tissue that is involved, hard, soft, or hard and soft tissue. So, but when we try to imply this classification into a simple cleft lip palette, what we could see, even in a simple unilateral incomplete lips, they have a heterogeneity. They don't look all same. It could be a simple type 1 of a submucosous cleft lip, or it could be an incomplete lip which extends behind the white roll involving the nose. So here the extent of deformity is much more effective than in the normal, what you see in the type 1. Same thing when you look into a complete unilateral cleft, it could be with or without Simonard's band, or with or without complete collapse of the nasal dome, or the difference of the alveolar ridges plays a major role in the outcome of this or whatever surgical technique we utilize. Same again when you look for a bilateral, it is about the symmetry involving the nostrils or without nostrils, or the cleft is involving the nostril. It's an asymmetrical cleft with the involvement of the nostril or without involvement of the nostril. It could be again the key here is could be again for a complete bilateral. Here is again with symmetry, or then is the premaxilla protruding or protruding very much away, or it's confined in the arches itself, or the cleft lip is there, the prolabral angle is less than 120 degrees, or it could be more than 120 degrees. If it is more than 120 degrees, our approach to it should be totally different. So the variant is so much of heterogeneity. With so much of heterogeneity, we should be able to identify these not by simple looking at them as a unilateral or a bilateral or anything, but we should be able to describe under what sort of form it falls in, what sort of subunit it falls in, even if it is a simple lip or a palate as you see here. Now the key is when you look at the craniofacial clefts, yes, it was classified very way back by Bochai, where he said that a cleft that is induced medial to the infraorbital foramen or lateral to the infraorbital foramen, as you see here. This is the medial and this is the lateral. And of the American Association of Cleft Palate Rehabilitation has given a good model based upon what you call as an embryological model recommended by Gerhard Pfeiffer, where he said the clefts can happen either in the midline, starting from the mandible, going upwards till the nose, or it could be the going obliquely into the towards the auricular area or ocular. So they classified as ocular clefts, auricular clefts, or the clefts involving the mandible or maxilla. But it was the gold standard classification that was proposed was by the Tessier's classification. Here he is able to identify the exact zone where the cleft lies. He said the cleft could be in the northbound or in the southbound. The northbound or the southbound, he has described it based upon the involvement of the lip to nose, ocular, the facial area or the auricular area. And he has subclassified them starting from 0 to 14. 0 is the one that starts in the midline. So when we look the same classification into our morphological classification, we have to look into this involvement of the softer hard tissue. So what you see here is a Tessier 0, the involvement of the lip in the nose and sometimes extending to the nasofrontal area. But the moment it extends into the frontal area, then we call it as a 14. Now this is a classical Tessier 2, what you call is as a nasal cleft. Here the nose is involved only in the superior and the anterior aspect of the nose, that is in the ala. So here we classify it could be again subclassified as a minimal, moderate, or a severe one. And the Tessier 3 is where the clefting is happening at the base of the ala. As you see, the base of the ala is involved. So we call it as a Tessier 3 clefts. Now the Tessier 3 could be again 4. The Tessier 4 could be unilateral or bilateral, as you see here. Now the involvement of the cleft extending from not only from it doesn't involve the nasal cleft or the ala, but involving into the ocular area. Now the ocular area is mainly extended into the medial canthal area. And the Tessier 5 is the one which is extending exactly into the middle of the interpupillar area. Tessier 6 are quite rare. It is where it's not exactly onto the lateral canthal area, but very much a few millimeters from in between the midline to the lateral canthal area. Now Tessier 7 are the most common of all the clefts what you see. This is also called as the lateral cleft, lateral facial cleft. Here it is extending basically horizontally along the modulus of the lips, so that it extends to sometimes even to the auricular area. Suppose if it extends into the auricular area, most of the time it is associated with the hemifacial microsomias. Now, sometimes the nature is so much of in combinations. It could be a standard Tessier 1 combination with a Tessier 4 and a Tessier 7 cleft, or it could be a Tessier 4 or a Tessier 5 cleft as you see here, or it could be 5 and 7 again here. Now, it could be sometimes so much affecting the face as a 3, 4 and a 30 facial clefts. Now, there are clefts that not only involve the soft tissue, but they involve the soft and the hard tissue defects. So when you take a CT scan, even though it looks like a very simple Tessier 0 involving only the lip, but you can see the alveolus is also involved, so that it is an involvement of not only the soft tissue, but also the bony area. Again, as you see for a Tessier 2 here, it is involving the bony aspects of the nasofrontal area here. Again, for a Tessier 3, you can see the ensophaloceles very marked, so that the extension is not only in the soft tissue, but also in the hard tissue. So our approach and the treatment plan is involving not only the soft tissue correction, but also involves the hard tissue correction. And this is a Tessier 4 involving hard and soft tissue both together. And as I mentioned about the Tessier 7 cleft, sometimes has extension into the auricular area, and is quite well noted these sort of things in hemifacial microsomia, where you can notice that this is a type 2B hemifacial microsomia involving the lateral aspect of the modulus, calling again as the lateral facial cleft. Now, sometimes it could go 0 to the 14, as I mentioned, when the midline cleft starting from the lip extends into the frontal area, you can call it as a 0 to 14. And the 0 14 sometimes could be quite very extensive, as you see here with an ensophaloceles. Now, how do we manage these craniofacial clefts? As I said, the principle is based on identifying the involvement of the soft tissue and the hard tissue. So the soft tissue management, you need to identify the subunits. Is it the lip? Is it the nose? Or is it the eye? So again, we need to notice the subunits involving that simple unital area like a vermicular notch or a philtral ridge or even a medial canthal ligament. All these things has to be considered and try to be reorient the normal architecture. So the lost architecture has to be reoriented. And the hard tissue management is always by involving bone grafts like any other hard tissues like resection of encephalocele, hypertelorism correction, orthognathic surgery or distraction surgery. Now coming to this part one of the soft tissue management, the soft tissue management, it could be for a simple unilateral cleft lip as you see here. This is the standard incision design. We call it as a morphofunctional incision design. So this incision is a combination of both Pfeiffer and Millard's incision. The most important thing is identifying the muscles. The key is trying to do a facial mask elevation of a very good wide subperiosteal dissection on the cleft side. And most important, again, as I say here, is a septum. The septum has to be isolated from both the sides from the mucoperichondrium, should be shifted out of the midline, shift into an anatomical position, and then has to be repositioned. And a periosteoplasty is performed. Then once you do all these fundamental steps, everything falls into normally in its place. Like this is the one of the type of outcomes you can get when you do this morphofunctional approach for a unilateral complete cleft lip. Now, even for the bilateral, it is a quite similar incision design what we use. What we do is we use a Pfeiffer wavy incision onto the prolabium area, extending this incision behind the columella, because there is so much of skin that is available behind this columella. This has to be mobilized so that the lengthening of the prolabium and the columella can be performed. And we use the lateral segments as standard Millard incision, so we can get a good rotation of the lateral segments. Again, as I'm here, we need to identify the muscles, dissect the muscles. A very wide subperiosteal dissection on both the segments is performed. Even a very projecting premaxilla can be closed very primarily by using this philosophy, what we call as morphofunctional repair. And the most important thing is creating the vestibule. The vestibule has to be prepared very well so that using the same the tissues that is available on the prolabium, so that you have a very mobile lip. The lip should be able to move around everywhere. And the muscle exerting forces onto the projecting premaxilla should be directly forced onto the premaxilla. So any projection of the premaxilla could be easily rotated. And same time, because of the incision design, the columella height is maintained and the length of the philtrum and the prolabium is also maintained. And you can notice that because of even a projected rotated premaxilla like this, if you use this morphofunctional approach, then you can notice within matter of time, by the age of 3 years, you can notice that there is a good length of columella and a good amount of length of the lip itself. So the ideology here is the type of incision designs what we use and the philosophy of the dissection of the muscle and the subperiosteal dissection is important. Now, so what I say in a lip defect, it is a three-dimensional problem. You should address the nose, the lip, and the alveolus. So for this, the solution is to do a cheloplasty, septoplasty, and periosteoplasty. Now, there are different type of flap designs available for the soft tissue correction of craniofacial clefts. You could use a local rotation flap or a Z-plasties or a Pfeiffer wavy designs or a local rotational flaps like a nasolabial transposition flap or a nasal dorsal rotational flap or a forehead eyelid nasal transposition flap. So we have to design the flap in such a way that the soft tissue defect could be easily closed based upon the type of classification of cleft and involvement of that. So what you see here is a 014 facial cleft where we have used a very straightforward Pfeiffer wavy incision design where we did a midline separation of the face and then we could reposition it. At the same time also we did a lot of soft tissue and hard tissue augmentations using cartilage for the reconstruction of the nose, as you can see in the final outcome of this child. Now coming to the Tessier 2 facial clefts, these are quite most complicated. It's mainly because lack of soft tissue. Even though you can use a transposition flap or a nasolabial flap or a rotation flap here, whatever you do, still there will be a mild amount of notching that could be seen. Always this has to be revised in the secondary corrections by using auricular cartilage augmentation into the using it as a baton along the alar rim. Now, another most important thing what you can see here is the Tessier 3 facial clefts where there's a total lack of both the inner lining and the outer lining. So how do we do it? So the inner lining is obtained from the margins of the inner lining is obtained from the margins here. So we take this skin and we transpose it as an inner lining here. And then we use the rotation of the forehead flap to the upper eyelid and the upper eyelid flap to the nasolabial area here. So by closing these areas, like as you see, we call it more like a starfish incision, where the walking of the starfish, how the flaps coming from the forehead onto the upper eyelid, from the upper eyelid to the lower. By doing this, even a very wide nasal defect of a Tessier 3 can be easily be corrected. And sometimes it is not only involving the Tessier 3, but you can notice here even the classical standard Tessier 1 is also involved. So we have to use the same morphofunctional philosophy of doing the septoplasty. So we do an open rhinoplasty even in a very young babies, where we open the septum, reposition the septum, and recorrect everything into the normal architecture. And then this is the type of outcome what we can get. The closing of the floor of the nasal ala, and also the lip can be closed in one single sitting. The Tessier 4 facial clefts. Here again, we strongly recommend by using the Pfeiffer wavy incision. This incision is a very dynamic incision where it stretches and elongates the skin. At the same time, it creates the scar line in such an aesthetic way that it does not have any Z's or any W's anywhere. So we can use this very extensively, correcting it and repositioning the lower eyelids by using a skin grafts where it is needed. For a very extensive Tessier 4 facial cleft, as you see here, of course, unfortunately, we cannot save these eyes because the child has a missing eye in one side, and the other side has already the vision was lost when she was born itself. A very wide Tessier, bilateral Tessier 4 can be corrected again using these Pfeiffer wavy incisions. Now, a combination of Tessier 2, 3, and a 7, as you see here, even an extensive Tessier 7s like this, involving upward, going upward, could be easily used a Pfeiffer wavy incision, a soft tissue correction. The aim here is to recreate the modulus. For this, you need to identify all the muscles, reorient all the architecture of the muscles here, at the same time also trying to fill up as much of soft tissue underneath the skin so that this sort of depressions can be corrected very easily. Now, this is again a Tessier 3, 4, and a 5. Again, we have used a classical Pfeiffer wavy incision along all these areas and reorienting all the normal architecture. Now, what we do in a craniofacial cleft where the soft and hard tissue reconstruction has to be performed. I would use this not as a repair, but I would use the word called as a reconstructive procedures. The principles are standard. We have 4 principles. The first principle is to combine as many small procedures into a practical one surgery to maximize the benefit of surgery early on the patient. The second principle is to decrease the infection rate by limiting combined intraoral and intracranial procedures. The third principle is to decrease the number of revisionary surgeries. The fourth principle is to maximize the overall long-term functional and aesthetic results. A fully intracranial corrections of orbital hypertelorism is difficult in children younger than 2 years old and almost impossible in younger than 12 months old. The simple reason is when you try to do the infraorbital cuts, to do an en bloc orbital osteotomy, the tooth buds are very high up at the infraorbital area. So in these situations, it's quite well recommended to do a facial bipartition procedure than a orbital hypertelorism medialization. So craniofacial clefts, usually underlying tissue defects, manifest what you call as hypertelorism. So it could be a severe hypertelorism. Now, in all severe hypertelorism, it is quite indicated to do an as an intracranial approach. So what you see here is a standard Tessier 0 to 14 craniofacial cleft. It is not only involving the nose, but also extending to nasofrontal area. You can see the classical Hudo appearance of the skin and the hairline dragging down with a severe hypertelorism. So what we do here is we do a standard 3D model reconstructions, and then we do a bicoronal approach, expose the anterior cranial fossa, and then the neurosurgeon helps us in retracting the anterior cranial fossa, and the orbital osteotomies are made. So we can use it's a spectacle osteotomy or a block osteotomy or a facial bipartition based upon the age and the involvement of any encephalocele in that area. If there is an encephalocele, it is very impossible to do a spectacle osteotomy because you have to resect the midline encephalocele. So, and the transfrontal craniotomy is performed. The periorbital osteotomies are extended laterally into the infratemporal area, going down to the zygomatic area. And then the orbital roof osteotomies are performed from the anterior cranial approach so that we can visualize it very neatly. And the orbital approximation is performed by simple removing all the excess bone that is in the in between both the orbits. And then once it is removed by a simple medialization pressure with your fingers, you can easily mobilize the orbits together and correct all that widening of the hypertelorism, and the finishing osteotomy is performed. And all the leftover gaps here, what you see when you medialize, all these have to be filled with proper bone grafts. That is the most important. So there's ample of bone that is available coming out from the frontal osteotomy. What we do, the frontal bone, we split it into the middle in a sagittal way, so that we can get a good amount of bone. You can see the inner cortex can be taken separately, and the outer cortex. The outer cortex goes back into the normal place, and the inner cortex is used as a bone graft, and we fix it. All the lateral defects are totally closed. Wherever there is amount of defect is there, we close all using this bone grafts. So to reduce the relapse, the aim is to close all these the gaps that are happening due to the medialization of the orbits. And you can notice the amount of reduction of the intercanthal area. At the same time, we do the nasal reconstruction, giving a midline approach. And then this is the type of outcome what we can obtain by correcting the 014 craniofacial flap. Now, sometimes these are quite extensive with an encephaloceles, and then these have to be performed. I just got a small video here where it can show exactly how it's performed. So we do the transfrontal orbital osteotomy and do the orbital movements. So we do an en bloc medialization of the orbits totally together. And then we can correct the nose primarily at the same time. And if we can always use the calvarial grafts for reconstruction of the nose. And sometimes we have very extensive hypertelorisms involving 014s, as you see here, even such a huge one where we need to resect more than what I could say 4 to 5 centimeters of bone intercanthally here could be performed, and medialization of the orbits can be done like this. So what I would like to say in the end here is a craniofacial cleft repair is not a complex surgery. Diagnosis of the defect should always be made based upon the morphology of the defect. Identify the defect in a morphological subunits. Correct each subunit collectively or independently based upon what it appears as on your examination and on investigation. If you follow these small principles of identifying where the defect is and identifying the subunits and correcting these subunits, definitely the surgery can give you something called getting a good smile on your patients. Thank you very much.
Hello.
Yes, Janavi. Yeah.
Yes, sir. That was really enlightening. Thank you so much, sir. Can we move on to the next speaker?
So do you have the questions later or right now?
I think, sir, later would be better. So we can finish up all the
What
speakers
time do you
and then take
the questions to be there?
Sir, around 8:30.
Perfect. I'll be there around that, right that time.
Okay. Yes, sir.
I'll be there for a couple of lectures and then I'll be there. Thank you.
Okay,
so I
sir.
log out now. Stop sharing. Stop sharing. That's done. Then I mute myself.
Yeah. So moving on to our next speaker, that is Dr. Nasir Najmi, professor and the coordinating program director for oral and maxillofacial surgery at the University of Antwerp, Belgium, director of the team for cleft lip and palate and craniofacial anomalies at the University Hospital, Belgium, chairman of the Department of Cranio-Maxillofacial Surgery at the University Hospital, Belgium. He gained his DDS and MD at the Catholic University of Leuven, Belgium, basic training in maxillofacial surgery in Belgium. He's done his fellowships in oral and maxillofacial surgery in Houston, Texas, and in cosmetic surgery in Miami, USA. Fellow of the European Association of Cranio-Maxillofacial Surgeons. He's done his PhD at Radboud University, the Netherlands. Areas of expertise is orthogactic surgery, facial rejuvenation surgery, cleft and craniofacial deformities, implantology. Welcome, sir. Over to you.
Thank you very much for the introduction, and thank you for providing me and inviting me to lecture on the long-term follow-up of our treatment protocol in patients with Pierre Robin and obstructive sleep apnea. The most acceptable hypothesis on pathophysiology of this condition following me is the oligohydramnios uterine abnormalities that cause mandibular hypoplasia. And because of the displaced mandible and posteriorly displaced tongue, the tongue positions itself posteriorly and superiorly, preventing palatal shells fusion between the 8 and 10 weeks of gestation. And at birth, we have microcnesia, glossoptosis, and airway obstructions because of the posterior and superior position of the tongue, which a lot of time, depending on the size of the cleft, it might even be locked into the cleft area, causing severe obstruction symptoms like stridor, intercostal retraction, oxygen desaturation, and feeding problems. The reason of the feeding difficulties is mainly upon the microcnesia because of the retroposition mandible and the posterior displacement of the tongue. The kids have difficulty with compression of the nipple. They have difficulty in obtaining seal, and the suck, swallow, and breathing coordination is disturbed. And of course, because of the retropositioning of the tongue comes in contact with the soft palate, and it can also be even locked into the palatal cleft. Well, I will show you in shortly a diagram of our treatment protocol. But what we usually start with non-invasive treatment, prone positioning, using nasopharyngeal airway to bypass the posterior positioning of the tongue. And this can be even in combination with CPAP. The more invasive treatment, the only invasive treatment that we perform is the distraction osteogenesis, but you'll also have in the literature lip-tongue adhesion, which I don't think in the modern surgical approaches has no place, and the tracheostomy is really the last option. There are alternatives in the treatment of these patients. One of them is retracting of the mandibular traction using different kind of devices. Even sometimes, this you see the traction device to bring the mandible forward, to put the mandible and the tongue in a more forward position. I've even seen putting a wire circumferential in front of the mandible that caused the cheese wiring through the mandible and through the skin of the chin. Again, the only invasive treatment that we use in Antwerp is distraction osteogenesis, but it has the more significant effects on obstruction type 1 and 2. So what is important is to know which kind of obstruction we are talking about. If the tongue is at a level below the soft palate, we are talking about type 1. If the tongue is at the level or above the soft palate, we are talking about type 2 obstruction. When you have the lateral pharyngeal collapse, the medial collapse of the lateral pharyngeal wall, we're talking about type 3. And if there is a sphinctering manner of constriction, you're talking about the obstruction type 4. So it is of paramount importance to preoperatively examine and find out where the level of the obstruction is. And therefore, we use a flexible laryngoscope. And of course, a pulse oximetry, you need to monitor the oxygen level in these children. And if there is problem with the saturation problem, then we need to perform polysomnography. Polysomnography is a very strong tool who gives us an idea about the frequency and the duration of obstruction, the severity of the obstruction, and even if there is the detection of the central apnea, detection of the apnea, if you have minimum 5 episodes of apnea of more than 10 seconds per hour, we speak about the sleep apnea. Here you see the R algorithm in the treatment of the Pierre-Robin patients with Pierre-Robin sequence. If there is desaturation, then we perform polysomnography. And we also need to find out where the obstruction level is. So you might do a nasoendoscopy, a bronchoscopy. If there is no obstruction observed, but still there are saturation problems, then one might think of the central nervous system problem or a pulmonary the obstruction because of the pulmonary source. If the obstruction is the infraglottic or glottic obstruction and nothing helps, even not a CPAP, and then we are obliged to do the tracheostomy. If the obstruction is the supraglottic obstruction, then we do the positioning, we use a nasopharyngeal airway, CPAP. If none of this works, then the final option would be distraction osteogenesis. We have been performing distraction osteogenesis from 2 weeks after birth up to 4 months. The reconstruction of the palatal cleft is done in single stage at the age of 9 months in small to moderate palatal cleft. If the hard palate is involved, if you really have a huge horseshoe palatal cleft, then we do it in 2 stages. The soft palate closure at the age of 9 months, and at the age of 18 months, at the latest 20 months, we do the hard palate reconstruction. We have seen that then by performing the soft palate reconstruction adequately and muscle realignment of the soft palate, because of the function of the soft palate, you have the diminishing of the size of the palatal hard palate cleft so that it can much easier be closed at the later age of 1.5 years. As you see, we use Molina extraoral mandibular distractor, but the procedure is done intraorally in severe cases of mandibular retoognasia. Intraoral approach, exposing mainly the mandibular angle area. Then I do the corticotomy with the piezo device, so you can use a little saw or even a round bore, it doesn't really matter. And then we perform a digital fracture at the mandibular angle. And then with we put the 2 pins, posterior and anterior, of the distraction of the corticotomy. Very important is that you pinch the skin between the 2 inserted pins, so that by distraction you don't have a terrible scarring. The wound is closed intraorally, and we start distracting at the day of the surgery, at the rate of 2 millimeters a day. In the neonates, you do not need to wait for callus formation. You can right away start with distraction, so that after a week, you have like 14, 15, 16 millimeters of distraction. This is Sydney. This is my very first case that I did at the University Hospital in Antwerp. at the year 2000. It was more than 20 years ago. We used to check the consolidation using radiographs, which I do not use anymore. We don't take pre-op CT. We do not use radiographs. I don't want radiation in these children. You can perfectly follow up everything just clinically. At the end of consolidation period, we take out the screws, the pins, and the distractor just in the during the consultation. You know, sometimes I was obliged to remove a distractor after 3 weeks after distraction, but usually we try to keep the distractors about 6 to 8 weeks in place. This is Cindy, this is the first patient. After 7 years, you see the scar is barely visible. That's the dentition. Radiographs at the age of 7 years. These pictures are taken about 4 years ago when she was 16 years of age. You see almost no inconspicuous scarring. And she only had, after palatal closure, she only had orthodontic treatment. Here is her speech. Skål.
Skål.
Auto.
Auto.
Ball.
Ball. 67, 68, 69, 70.
70. Can you give me a big smile? So you see that she has good function and good speech without speech therapy. Well, one of my residents, of last year resident, Dr. Kalantari, she's performing a long-term study and long-term analysis of the teeth and the jaw growth in our series of patients. We included all patients with isolated Pierre-Robin sequence, all patients with complete documentation, because many of our patients come from different part of the country. They are treated, they are distracted, they have the palatal cleft closed, and then they move back to their own region and are further followed up by local health providers. And so we included all the patients that stayed for the follow-up at the university hospital, those who were born between 2000 and 2015. All patients were treated by the same surgeon. The exclusion criteria were those patients with neuromuscular diseases, with syndromic patients, and those with less than 5 years of follow-up. In total, 48 patients were treated, and only 19 fulfilled the inclusion criteria. So from this number of patients, we distracted 22 of the patients. 9 of them stayed at the university hospital for further follow-up. The primary outcome of the study was the growth of the mandible, just to see how the mandible growth based on cephalometric analysis. We also looked at the dental development, if there were agnesia, if there were shape changes, root malformation, regional positional changes after distraction osteogenesis. We also looked at the secondary outcomes. We looked at the obstructive breathing patterns with overall satisfaction of the patients and parents. If there was a need for speech therapy, we looked at the scar, and the function of the inferior alveolar nerve and the marginal mandibular nerve. And the results showed that there were overall not a greater tendency for an open growth pattern in patients who were treated with distraction osteogenesis in comparison to the control group. Those were Pierre-Robin sequence patients who did not had distraction, were treated with unconventional way. As you see here on the left side, we have a cephalogram of a 13 13-year-old patient with distraction osteogenesis, and this is a 13-year-old patient of our series without distraction. And in both you see an open growth pattern, which was not significantly different. If you compare the size of the mandible to the normal patients, then we see that the ramus of the mandible as well as the body of the mandible are significantly smaller in Pierre Robin patients, and there was significant difference in SNA. Looking at the dental analysis, in the conclusion, we had no significant difference in both group. Most often were the second premolar missing. Premolars missing. In one patient, we had a positional and the change of the shape of the first molar on one distracted side. All patients were extubated at 4 to 5 days postoperatively. We keep the patients intubated for few days postoperative so that we are sure that due to the distraction, we already have a good positioning, anterior positioning of the tongue, and the swelling, postoperative swelling is under control. Then the patients are extubated, and the distraction pins were removed at least 4 weeks postoperatively. And the feeding started intraorally 2 weeks after the surgery, intraorally using a Haberman feeder because of the presence of the cleft palate. The short-term complications were screw loosening in one patient that was replaced under sedative anesthesia. We had a local infection pin insertion with another patient who was treated successfully with topical antibiotics. The long-term, there were no long-term complications. The scar was in all patients acceptable. We had intact sensibility and function in the inferior alveolar nerve and marginal mandibular nerve. As you see, the scarring is inconspicuous, barely visible. All the patients, all the parents filled in the questionnaire about their satisfaction, and they were all 100% of them very satisfied with the total care of their children. Looking at speech therapy, in the distraction group, only one patient needed speech therapy because of the swallowing difficulty, and 3 patients had speech therapy for swallowing and articulation problems in the control group. Interestingly, during the 2 postoperative years, all patients showed a normalized polysomnography. However, 2 patients had the recurrence of sleep apnea at the age of 7 years. One with a normal occlusion and one with even a class 3 occlusion. Well, because of the success of our protocol, I introduced these distraction cases in my center of excellence that we built in the south of Iran, in Shiraz, through Najmi Foundation. And in the past 5 years, we have already treated over 70 patients with success. This is Hadi, who was my first patient that I treated in Iran. Nowadays, the local surgeon take care of the distraction procedures. And as you see, she had lip-tongue adhesion. She had cheese wiring with traction. She had been through a lot of stuff. And at the age of 3 months, she already had 5 episodes of cardiac arrest. And 6 days post-distraction, postoperatively, she was extubated, and she's doing now, it's a picture that I took from her last year. She's now, I think, 4 or 5 years old. Very nice girl and functioning normally. So as a conclusion and take-home messages, of course, we start with a conservative approach, prone positioning, nasolabial airway, shows a good success rate. And, you know, with conservative treatment, over 50% of these children do not need any invasive treatment options. Distraction is a successful and viable option. What is very important is to diagnose correctly and see what the type of obstruction is. In type 1 and type 2, you can always 100% be sure that that the distraction will be successful. I thank you very much indeed.
Thank you so much, sir. That was really enriching. So I'll move on to our next speaker, Dr. Mustafa. So Dr. Mustafa is a director at Kanachur Institute for Craniofacial Anomalies. He's the former president AOMSI 2010 to 2011. He's the director AOMSI Orthographic Fellowship, past honorary general secretary of the Indian Society for Cleft Lip, Palate and Craniofacial Anomalies, recipient of International Rotary Award for his contribution towards poor cleft children, conducted more than 1,700 cleft-related procedures, delivered guest lectures in various international and national forums. Hello.
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 Yeah, next is my.
Oh, sorry, sir. So next is Dr. Ting Chuing Lu, Taiwan. Yeah, I'm really sorry. He's working as an attending surgeon, Craniofacial Center,
after the
Changwing Memorial Hospital. Undergraduate education is Taipei Medical University, Medicine. Residency, Plastic and Reconstructive Surgery, Changwing Memorial Hospital, Taiwan. Pediatric Craniofacial Fellowship, Hospital for Sick Children in Toronto, Canada. Observership, Boston Children's Hospital, Boston, USA. Published many articles and has presented many papers in national and international forums. Sorry, sir. Welcome. Over to you.
We are sorry, Dr. Lu is madam, not sir.
Hello.
Okay. Yeah, welcome, Dr. Lu, please.
So thank you for inviting me for this speech. So my topic today is craniosynostosis, and because this is a big topic, so I'm going to focus on what we do in Chang'e Memorial Hospital, and because we do the computer virtual planning and design, so today I'm talking about how we do it. So for the craniosynostosis, it's a premature fusion of one or more suture in the cranial valve, and it can be classified as single suture or multiple suture, or it can be classified as non-syndromic or syndromic. Non-syndromic patients counts about 85%, and syndromic patient counts about 15%. Different suture closed result in different shape of the head, and the picture shows the examples of the single suture craniosynostosis. The problem of the craniosynostosis are the possible increase intracranial pressure, the ocular problem, the airway problem, and possible neural, developmental, or psychosocial problems. The management of craniosynostosis in Chang'e Memorial Hospital, we are interdisciplinary team care. We have a plastic surgeon, neurosurgeon. We have an image lab. We have an engineer working with us. And we do cranial valve surgery combined with the neurosurgeon. Usually we perform the surgery around the baby is 9 to 12 months old. If we do endoscopic, we will perform in 2 to 4 months. The post-op ICU care is for 1 to 3 days and admission is totally 1 week. We perform the CT scan pre-op, post-op. We have an O-arm in the OR, and we also follow up the CT scan 6 months later. And we will follow up these patients until 18-year-old. So the surgical options, including for the unilateral or metopic or bicoronal suture, we will do the frontal-orbital advancement. For the sagittal suture cranial synostosis, we do total cranial valve reconstruction. In some cases of the sagittal cranial synostosis, we do posterior cranial valve. And for the endoscopic, we perform between 2 to 4 months. Actually, I only do with the sagittal cranial synostosis. For the syndromic cases, we will do the posterior valve distraction around 6 to 12 months. The cranial valve remodeling surgery involve the remove of the affected bone and remodeling of the bone into the most appropriate shape for the patients and placement and fixation of the remodeled bones. However, the design is quite subjective and depends on the artistic capacity and experience of the surgeons. Usually excellence in the hands of the more experienced surgeon. However, it is more often to error in the less experienced surgeons. Since 2011, computer-aided design were published in the papers with case reports. And John Phillips in Sickets used 103 normocephalic skull based on the 8 to 12 months of CT scan used for the computer-aided manufacturing. I was trained in Sickets between...
In one season, we used to have all craniofacial cases only continuously.
So I was trained in Sickets between 2016 to 2017. They have 3 Bandol template plates in different ages for frontal orbital advancement surgery. They also have a normocephalic skull model for the cranial valve remodeling, usually for the posterior valve shape. Solomon in 2015 represent 2 cases of the frontal orbital advancement using computer-aided design and computer-aided design for the surgery. The costs talking in the paper is about 4,000 to 6,000 USD. So today I'm going to present our in-house virtual surgical planning and 3D printing workflow at Tonga Memorial Hospital. The cost for each patient is about 400 USD. So it's much cheaper compared to the if you done with a company. So the first step is we import the data into the workstation, and we have to do the initial preparation. We use the mimics for the dealing with the CT scan, and the cervical spine is removed. So the 3D skull image is digitally sent to the craniofacial surgeon. So the craniofacial surgeon who outlines the bone flap design based on primary diagnosis of the type of the cranial synostosis. And the engineer will design the bone parts in the software. So the skull STL file will export it to the 3D print chute. We use the materialized software, and we will match the standard age-matched skull template in a STL format. and we'll pair the normal cephalic skull model with the patient skull. And we'll digitally design the patient skull shape and size as the standard pediatric skull template. Finalize the engineer will design the cutting guide, and he will also use the inner surface of the final skull shape. We use the 3D printer, which is biocompatible material. So the total cost of each patient is about 400 USD. So in the following, I'm going to talking about each kind of a single suture cranial synostosis, how we design the surgical planning. So for the sagittal synostosis is the most common of the cranial synostosis. Usually the ICP elevation is around 17%. Most of them, they have a speech issue. When you see the patient, you'll find he has a boxing forehead and narrow temporal area. For the AP view, the AP dimension is quite long. From the lateral view, you can see the high point of the skull is in the anterior. Usually for the normal patient, the high point should be on the posterior. So the treatment protocol in Chang'an, if the patient come early, I was talking with the parents about the treatment. They can do the endoscopic suturectomy around 2 to 4 months. And with after surgery, they have to put on the molding helmet until 1 year old. If they come late, they can do the cranial valve reconstruction around 9 to 12 months. Like this patient, for example, is an endoscopic suturectomy. We cut in the middle around 4 to 5 centimeter width in the from the anterior fontanelle to the posterior fontanelle. And we also do the cutting on the laterally, anterior, and posterior. This is, we designed the cutting guide for the endoscopic suturectomy. So you can see after the surgery, it improved a lot of the skull shape. And this is the helmet the patient need to wear until 1 year old. So for the total cranial valve reconstruction, if the patient come late, it is better to perform the surgery around 9 to 12 months. Of course, the picture show here, the case is come very late. He came around 3 years old. So we designed the total cranial valve reconstruction. So my methods for the total cranial valve reconstruction is based on the butterfly methods by John Phillips in sick kids. So the logic of the reconstruction is you have to turn this in the center about 180 degrees. And for the parietal area, you change. You just shift this one to here and this one to here. And for the posterior part, you change this to this side and turn 90 degrees. So that's the logic of the butterfly methods by John Phillips. However, I'm not the very experienced surgeon, so we do the computer design. So I use the butterfly methods, putting into the computer, and we do our design in the computer, And for some cases like this case, the forehead is quite normal. I didn't do the forehead reconstruction. I only used the barrel stack methods for the temporal area. Of course, if you don't like the butterfly method, you can change another methods like this one. You turn the posterior cranial valve about it's 180 degree and move it upward to make the high point to the posterior valve. Then shorten the AP dimension. So that's the other method I use for the sagittal, the posterior valve expansion. For the unicoronal synostosis, is the second common of the cranial synostosis. Usually is female predominance. So when you see the CT scan, you can find the eye shape on the affective side is more like vertically rounded, and the nose is deviated to the affective side, and on the affective side is more bulging. If you took the plain X-ray, you can find that there's a helicking eye sign. Actually, for the frontal orbital advancement, the most important is the bando. You have to plan the bando usually according to the normal site. However, there's no normal site in a unicoronal cranial synostosis because usually the normal site is more boxing here. If you put the skull to the computer design, you can find actually the design is very simple. Usually I turn 180 degree of the forehead bone, and you cut in the middle. And for the effective side, you just cut here, and you change the position, and you can find it's quite very easy and simple. Usually you just need like 3 pieces, then you can do the reconstruction. You can see the final result is quite good. So that's the other example of the frontal orbital advancement cases for the unicoronal. So you can see the design is quite simple. Usually 3 pieces is okay. If you do the pre-surgical simulation, you can find it's quite easy. For the lomboid, cranial synostosis is very rare. It's a posterior plagiocephaly. Usually happen 1 in 100,000 births. Usually you have to do the MRI before the surgery because there's a high chance of a Chiari malformation with the lomboid cranial synostosis. For the lomboid cranial synostosis, I found the design is more difficult because from the skull base, the lomboid cases is quite asymmetric. Usually you have to cut into multiple pieces to make it more symmetrical on the posterior valve. Usually you don't need to do anything on the cervical spine area if the patient has a Chiari malformation. If you only do the expansion, then the Chiari will improve. For the metopic cranial synostosis, usually is fused by 8 months. And we do the reconstruction in severe, moderate to severe form of the cases. Like these cases. For the design of the metopic, I turn like 180 degree and I put the bone graft in the middle to expand the forehead. like this is the other cases. So you can see very clearly here. I put, usually I turn like 180 degree, and in the middle is about like 1 to 2 centimeter in the middle, and you put a bone graft here. And for the bento is also the same. Usually you need a bone graft in the middle to expand the orbital bar. So today I'm not going to talking more about the multiple suture craniosynostosis, but I will mention about the postural distraction, because for the distraction, the device is quite expensive. Even in Taiwan, it's quite expensive, and it's not paid by the insurance. So if there's a design problem or there's a device problem, then we will have a big problem for these patients. So I think it's better to design before the surgery. So you can see in this case, we design before the surgery, and we put a like cutting guide, and we design how we move the bone before the surgery, and we know how where to put the device. And you can see there's we can put a drill here, and we have to make sure our direction is right, because usually for the postural distraction, there will be a problem if your direction is not right. So you can see from this case, there's a very good improvement of the skull shape. And also for the postural valve, the contour is quite smooth. In conclusion, so in the in-house 3D CAD/CAM design for the cranial synostosis, it can provide a pre-op surgical simulation and intra-op shaping guide. However, you still need a trained plastic surgeon to know how to design the reconstruction, and you have to have a very experienced engineer to work with you. And you need a good communication between the neurosurgeon and plastic surgeon. Usually for the experienced engineer, he designed the cases less than 3 days. So it's quicker and it's cheaper. The total cost for this design is only 400 USD. So thank you very much. That's my speech.
Thank you very much, Dr. Lu, for the excellent presentation. We will have the question at the end of the session. May I ask Dr. Janvi to introduce
Yes, sir. Yes, sir. So I'll introduce our next speaker, that is Professor Michael Ras from Austria. He served as the Director of Department of Maxillofacial Surgery, Hospital Wels, and the Director of the University Clinic of Craniomaxillofacial Surgery, Medical University of Innsbruck, Austria. He has won multiple scientific awards from the Australian and German Society of Maxillofacial Surgery for his pioneering work on condylar fracture treatment and 3D photogrammetric analysis of the face. He has been the founding member and on the board of directors of the International Bone Research Association in Basel, Swiss. He is a faculty member of the Association for the Study of Internal Fixation since 2008. He has also had numerous positions, including being the secretary of the Austrian Scientific Society of the Maxillofacial Surgery. The Clinic of Craniomaxillofacial Surgery of Innsbruck was declared an AO reference center under his aegis. Welcome. Over to you.
Thank you very much for your kind introduction. Sorry, some mistake. What happened? Sorry, just a moment. What is the problem?
Sir, you need to open the presentation through Zoom itself. Might be you go in the option for the screen sharing. You see the option there, right?
Yes.
Share screen. You go back to the Zoom view. And then could you see the option for the screen sharing?
I don't see it.
Okay.
Hallo?
Ja, can I ask
Schauen Sie noch mal zum Meeting zurückkehren. Ich komme jetzt irgendwie nicht rein. Ich verstehe es nicht.
Du müsstest mir noch mal das Teamviewer-Passwort geben.
Oh mein Gott. Was für ein Passwort?
Das war das mit Teamviewer, der sechsstellige.
Oh Gott, das dauert jetzt wieder. Das habe ich nicht gleich hier.
Sind Sie rausgeflogen oder was?
Ich weiß nicht warum. Ich habe eigentlich zum Freigeben gegeben. TeamViewer ist hier 757 376
Die ID habe ich schon. Ich brauche nur das Passwort.
HAH 445.
Not a problem, Professor. We have some time, so maybe.
Yeah, so it should be a moment.
It's perfectly okay.
Bildschirm freigeben, oder? Ach so, ich habe das Falsche freigegeben. Warten Sie rechts. Ja. Ja, schon, aber hier unten komme ich nicht auf die richtige. Die Leiste ist besetzt. Sehen Sie? Bitte. So today we are going to talk about hemifacial microsomia and hypertelorism. And let's start with hypertelorism. It's a symptom, of course, and not a disease. It means that the distance between the orbits is widened. And often this goes along also with the telecanthus. Hypertelorism is defined as interpupillary distance above the 97th percentile of the distribution in a normal population. What does it mean? In women, it would mean that a distance of more than 65 millimeters, and in men of more than 70 millimeter is called a hypertelorism. Now, if we just look at morphogenetics, how the face forms, you will see that the eye anlagen are positioned very laterally, and they migrate to the median. And if they are stopped or inhibited in this migration, then the result is a wide distance of the orbits. And you will also see that, of course, in this case, might be combined with a cleft, because if the mesenchyme does not migrate medially, this cleft may be left. Now, you see the opposite types of malformations of the face in the midline. Here, you don't have tissue in the midline, you have a median cleft, no septum, and the prosencephalon. And here you have the widened distance of the orbits, and of course, this goes along with a malformation of the nose. Now, there are many syndromes that go along with hypertelorism, as you can see. We won't go through this. It's just the same symptom. And the treatment, the surgical treatment, is about the same in all of these cases. And of course, it may also be associated with clefts, as we said before. Now, to go to the practical part, if you do an osteotomy of the orbits to bring the orbits more to a medial position, you can either do a so-called box osteotomy, an osteotomy on the outer side of the orbits, and one on the more dorsally on the walls of the orbit, or you may just involve 3 of the walls. If you use the 3 upper walls, then you will be intracranially, as with a box osteotomy. Beside this, to move these parts medially, you have to excise something in the midline, either in the midline itself or paramedian on both sides. The other type of osteotomy that only uses 3 walls to move the orbits medially is upside down, so you leave the upper wall of the orbit intact. In this case, you're not involving the cranial base itself. And then in all of these types, you can either stay above or below the infraorbital nerve. Usually you would stay below. Now, the third possibility to excise tissue in the median area is that you do it by partition, and then the excision goes further down, may reach the alveolus. If you move these parts to the medial, then you have to excise a wedge, of course, in the frontal bone because of the rotation. We have already spoken about the medial excision, could be this one or could be this one on both sides. You see, if you move this box medially, you would narrow the piriform aperture. Therefore, you have to take off some bone here so that you keep the entrance to the nose as wide as it was before. If you look at the skull base, this would be the area that you have to remove of the bone on the skull base. You may go further backwards. This would be the roof of the ethmoid. Usually you would preserve the cribriform plate and preserve the olfactory fibers. Now, if you have a hypertelorism, the axis of the optical nerve is increased. So you should reduce it to about 25 degrees. And if you have your lateral wall here, you should move it here. You can only do so because you move the contents. If you take out the medial part, that would be the ethmoid. You can see it on an anatomical atlas here. It is important to realize that you have to go back with the removal of bone behind the equator of the ocular bulb. Otherwise, you will not sufficiently move the eyeball medially. On the lateral aspect, you see that within the zygomatic bone, you may stay higher or deeper. That depends on the aesthetic needs that you have, whether you want to change this area also. Now, let's go to some examples. You see this child with a double nose, very rare, I think, to see that, and a hypertelorism. So we have to take out a severe amount of tissue in the midline, and primarily somewhere else, some bone graft was done here, but we had to move, of course, the orbits medially. Sorry. So here you see the outline of surgery. This is for the box osteotomy. These 2 parts of bone, of the frontal bone, of the nasal bone, have to be removed, and then the orbits can be moved medially. To see it from the lateral side, with the inner cut, you have to stay dorsally to the lacrimal apparatus to keep that intact. When you take out the bone that you have seen outlined, you will see the lacrimal sac, which is preserved as the lacrimal ducts are, and then you go backwards and remove the ethmoid cellula and take care of the fila olfactoria. After having done the outer and the inner cuts, here you see the cut on the greater wing of the sphenoid, then you can move this box medially. You can clamp it. Here you see the lacrimal groove with the lacrimal sac, and then it's necessary to refix the medial canthus, be it with a non-resorbable suture or with a wire, as I will show you later on. I will go into details in a moment. So after you have moved these two boxes medially, you would do an osteosynthesis. Usually we use small metal plates. And of course you have to bring in bone on the lateral side where the orbit is moved forward, and we also do an osteosynthesis here, and then we reposition the frontal bone that we took off. So this is the CT scan after surgery. You see here was the area that was excised. Here is the resection of bone to keep the aperture open. This was the amount of medial movement. Here is the bone that was transplanted to fill the gap on the lateral orbital wall. And this is the patient prior to surgery and after surgery. Of course, very often there is a surplus of soft tissue, and we don't like to excise it, but sometimes we have to. The scar here is rather inconspicuous. In another patient, I can show you the detail of the excision of bone here before you move the box medially into the piriform aperture. You see here, this is the excision, and this point then will come here, and then we will do the osteosynthesis, as you see here. These plates are used to direct the suture, be it a non-resorbable suture or a wire, in the right place so that the medial canthus is positioned correctly, which is very important. So you see, we nowadays most often use such hooks fixed to a titanium wire, which is then brought through a hole of a plate here and into a needle that you see here, and it's guided to the other side, and then it's brought upward here and fixed under the plate. And if you do it on both sides and fix this plate, of course, here, then you can direct very exactly where you want to have the insertion of the medial canthus. Here you can see. Often you also have to support the nose. You see a bone transplant taken from the calvaria to lift the nose up. And here, this was the starting point, you see, and this is what we gained. We brought the whole orbit, but also the canthi very well medially. We usually would wait a year or so until we decide whether we would excise skin or not. Another type of rare cleft, a type 2 cleft, and a clefted tongue, a bilateral, you see preauricular appendices and a hypotelorism. In this case, I used a inverted U-shaped osteotomy and excised the whole mid part. So we move this medially. You see this excision of bone. It could go down to the maxilla if needed, and then you would have the kind of bipartition excision in the median area. And then again, you look for the lacrimal apparatus, you look for the fila olfactoria, and then you could narrow it to a very high extent, as you see here. And this is the patient after the surgery. And some correction of the cleft here in the nose. It may be associated, the hypertelorism, with the encephalocele, as you can see here. So you would usually resect part of the encephalocele and reposition it, the rest, and then you would do the box osteotomy and bring the orbits medially and also close the gap of the bone in the frontal area. You see, this was done here, so these parts were moved medially until they touched each other, and the bone gap here was closed. And this was the baby after this procedure. Usually we would not do this surgery before the age of 3 years, but most often, if it's the possibility, we would do it before 4 years of age, because after 4 years of age, the vision might not be that good to see a spatial view. So this should be done before the age of 4. A combination of hypertelorism with a bilateral cleft that was operated primarily elsewhere. You see, this is the outline of the osteotomy, a box on both sides. The osteotomy on the inner side should be, of course, anterior to the posterior ethmoidal artery and anterior to the entrance of the nerves in the orbit. This is the part that should be resected, and these are the holes for the craniotomy. So here you see the outline of bone that would be resected, and this part would be moved medially. So here the performance, as you have seen before. In earlier times, we used saws. Nowadays, we mostly use piezo surgery. Here you see the bone resection. The osteotomy on the skull base is done here. Here is the dissection dorsally into the ethmoid to remove the ethmoidal cells. Then the orbits are moved medially. It's to be preferred that you have airflow even in the most upper part of the nose, that you don't narrow it so wide that you don't have airflow here, because the patient will not smell, of course. So this is preserved, as you can see. This is the fixation of the orbits cranially. And then to get a better aesthetic outcome, I also corrected the premaxilla, brought it backwards to restore a better position of the maxilla. And this is the patient prior to surgery and after. Now, the next thing that we want to talk about is hemifacial microsomia. This is a congenital disorder that affects the development of the lower half of the face. So it would be the first branchial arch and its descendants, the maxilla and the mandible, but not only the bony part, also the soft tissue that belongs to such a branchial arch. So it should be the skin, the subcutaneous tissue, the muscles, and maybe even the nerves. According to Prosansky, there is a classification from type 1 to 3. The type 1 would be the mildest form, where you only have a slightly asymmetry and the ramus of the mandible may be slightly smaller. In the type 2, the anatomic malformation is more severe, and you have some changes in the temporomandibular joint. The glenoid fossa is absent, and the condyle is deformed. In the type 3, there is no condyle at all, and to a various amount, even the ramus may be absent. Just give you an example of a fully developed case of this type. So you see the maxilla is hypoplastic, the mandible is hypoplastic, the midline of the maxilla comes off to the left side also of the mandible. Very often there is an oblique cleft here, and the earlobe is completely malformed, or there are only residuants. The outer auditory canal is not present. Very often the ossicles of the middle ear are missing in such severe cases. This is the mildest form with just an asymmetry of the mandible and maxilla and some dislocation of the orbits. The severer the case, the more is the skeleton changed. The zygoma might be underdeveloped, it might be completely missing. Here you see the type 2 with a deformed condylar head, and this is a type 3 where all the ramus is missing and there is no outer auditory canal and no tympanic bone. So to start with the mildest form, I was asked to the traumatologic department to look after this patient because he had an accident with his bicycle, and they recognized the asymmetry but could not find a fracture. So when you look at the appendix here, just anterior to the right ear, you know this is a hemifacial microsomia of a mild type. And in these cases, you just do a bimaxillary osteotomy to lengthen the maxilla on one side with a level 1 osteotomy. This is the downwards movement. You have to graft, of course, and then you adapt the mandible to the newly formed horizontal occlusal plane, and you have to shift the chin to the other side. You see, this is what we have shifted, and this is what you gain just with a bimaxillary osteotomy and then chin osteotomy, asymmetry as desired. Maybe you could have a closer look at the nose. It's always offered to the patients, but if they don't want to correct this mild asymmetry, we just leave it. Now, this is the full developed case of such a disease with a hypoplastic zygoma, missing tympanic bone, missing mandibular ramus. And your first concern is, of course, to reconstruct the mandible. But you cannot bring ramus into a good position unless you have a fossa. So you first have to build a fossa, be it in the same at the same time as you rebuild the mandible or earlier, and then you would bring in a rib graft with a cartilage that you can fix to the mandible on this side, and if the mandible is hypoplastic on the other side, you may as well distract it on the other side. Of course, you have to bit overcorrect it then first on the left side. So you see here the rib that is fixed to the mandible. Here you see it in position. Usually these ribs will grow, but it's not absolutely predictable whether it grows enough or even will grow too much. Usually it does not grow to the same amount as on the other side. And most of these patients that are corrected even well corrected properly. As you see, the child can open his mouth quite good, and the midline is kept even in mouth opening. And with orthodontics, you get a good occlusion. But when the child will be, let's say, 16 years of age, you usually have to redo surgery with a bimaxillary osteotomy. Now, if this transplant failed, as we saw in some cases, not in our hands, but sometimes it may fail, you could use vascularized bone graft, for example, rib pedicle on a branch of the thoracodorsal artery that supplies the serratus anterior muscle, which is fixed to the rib. And here you see the patient with a right-sided microsomia. If you lengthen the ramus on the right side or rebuild it at all, this patient had distraction osteogenesis before and a rib graft. They all had failed, and so we decided to have a vascularized bone graft. So this is what we gained in height for the mandible on this side, and of course you have to correct this and do a level 1 osteotomy to bring it down and have a good occlusal plane. So in a 3D model, you see here is the graft fixed to the mandible. Here you have the level 1 osteotomy with a down grafting. You have to bring in bone, of course, here to keep it in this place. And of course, as we said before, there is also a soft tissue deficit on this side, especially in the severe cases. So in the most mild cases, we just do a liposuction, but the more severe the case, the more likely you have to use a fat transplant, either a block transplant without vascularization, or you do a fat graft, for example, on the superficial epigastric artery that you might do the anastomosis here on the temporal artery and vein, or on the facial artery and vein. Here you see the fat graft in the cheek, and this is the patient prior to surgery and after level 1 osteotomy, transplantation of a rib pedicles on the thoracodorsal artery and a fat graft. Now, the case could even be more severe, as you see in this patient, where also the orbit is involved. It's a very small orbit with just a small rest of ocular bulb, very small orbit, no maxilla almost, so just with 3 germs of teeth here, no zygoma at all, no zygomatic arch, and also the complete ramus is missing, also part of the body of the man. So of course, this is a severe problem for recontouring the skeleton also, and in this case, it was decided to harvest a metatarsal phalangeal transplant from the right foot, as you can see here. This is the pedicle on the dorsalis pedis, and this is right after surgery and some time after surgery. This was put in here. So here you see the phalanx, here you see the metatarsus, and this is a real joint, so the child can open the mouth properly with this joint. And you see the huge distance between the lower jaw and the rest of the maxilla, and so I decided to do a distraction with the floor of the orbit and the lateral wall and bring this down, which we succeeded to do, and you see an almost normal orbit, which will later on take an epithesis for the eyeball, a graft of the calvaria here, And then we also distracted the mandible here, right in front of what was the angle. And then after removing this, we've made an osteosynthesis. But you see that we could bring into contact the teeth of this remnant of a maxilla with the lower jaw, and the midline is also restored. But all the soft tissue reconstruction still has to be done in this case. Now, as I said before, you may do a fat graft. Now, this is a case of a rhomboid disease, but you would do the same procedure for the soft tissue. You could, for example, just to give you an example, for a microvascular graft, you could do a latissimus dorsi flap or a gracilis flap that you may also connect to a nerve. The patient had its ramus colli of the facial nerve preserved, so I would do a nerve connection here of the nerve that innervated the latissimus dorsi muscle, and I connected it to the lip. And you see here the anastomosis of the nerve and the arteries, and this is the electromyography of the muscle here after it was in function. This was short after surgery with the incision for the connection of the muscle here, and this is the patient after soft tissue reconstruction. Now, another concern is the ear, of course. So we would rather do an ear out of resin and fix it to magnets which are fixed to implants in the temporal bone. Sometimes you have to augment the temporal bone to be able to put in the implants. Of course, I know you could do a reconstruction out of cartilage and the skin. And finally, one concern is the orbit. Now, many of these patients, if they have a more slight dislocation of the orbit, they prefer not to have the orbit repositioned, especially if their vision is okay. But this patient had otherwise small amount of dysplasia here in the maxilla, but a severely dislocated orbit, which was also smaller than on the other side. He had an epithesis, but it did not satisfy him. So also the nose comes off a bit to this side. So we decided to reposition the orbit, and the patient wanted it. You have to take out frontal bone to get access to the frontal base, where you do a box osteotomy, as you saw in the hypertelorism cases. So osteotomy on the frontal bone on the base of the skull, and on the medial called lateral wall, and on the outside here downwards and horizontally in the maxilla beneath the infraorbital nerve. Then you would take out part of the bone, of the frontal bone here, so that you could move the box upwards and then use this bone to insert it here. And then you can readjust the frontal bone. You could also augment the zygomatic bone and zygomatic arch at the same time, because usually this would also be hypoplastic. So you see this on the 3D CT scan. This is the frontal bone that was moved upwards. The bone from here was brought down here. So this is what we gained in height. This is the augmentation of the zygomatic bone and arch. And the lateral canthus and the medial canthus had to be refixed, of course, this one here, and the other one in the same way that I showed you in the hypertelorism cases, with a plate that goes in with a hole here where you want to fix the medial canthus And the wire is guided to the other side and comes up and is fixed here to the plate. So you see, this is higher now. It's smaller than the other side, but we wanted it to be this way because also the contents are missing. We also made a brow lift here and with some skin excision here and with a lift with sutures also. So, and this is the outcome of the patient prior to surgery and after surgery with the lifting of the right orbit. That ends my presentation. I want to thank you for your attention.
Amazing lecture, sir. I mean, it was really very much interesting to all.
Thank you very much.
Thank you. Dr. John,
Yeah, thank you so much, sir. I'll move on to our next speaker. Dr. Mustafa. He is the director of Kanachur Institute for Craniofacial Anomalies, former president of AOMSI 2010 to 2011, director of AOMSI Orthodontic Fellowship, past honorary general secretary of the Indian Society for Cleft Lip, Palate and Craniofacial Anomalies, recipient of International Rotary Award for his contribution towards poor cleft children, conducted more than 7,500 cleft-related procedures, delivered guest lectures in various international and national forums. Welcome, sir. Over to you.
Good evening, everybody. I'm sure you all can hear me. Am I audible?
Yes, sir. Clearly.
Okay. Can I go ahead?
Please, sir.
Okay. Thank you. So my lecture will basically cover on how to manage the cleft maxillary hyperplasia. Class 3 malocclusion is just one of the indications for midface deficiency. Its absence need not necessarily preclude the diagnosis. So the manifestations involve the paranasal, nasal, infraorbital, zygomatic region, and also in the occlusal levels. More often, the focus has always been on the occlusal levels and less focus on the other areas that I have mentioned. So there should be adequate focus on all these areas. So this is a typical case of cleft maxillary hyperplasia. You can see a positive lip step. In this case, you can see an almost an edge-to-edge bite. In severe cases, you will see a negative overjet, and this is a bilateral cleft maxillary hyperplasia, severe retrusion of the maxilla, and there is overclosure of the mandible. So the presentations could vary. This patient, again, has a severe cleft maxillary hyperplasia as a consequence of cleft palate deformity only. And here is another child with a bilateral cleft maxillary hyperplasia with severe retrusion of the midface manifested at a very young age. So what I'm going to speak about is the deformity, the influencing factor, early intervention, conventional orthodontic surgery versus distraction osteogenesis, hypoplasia in bilateral clefts, single jaw versus double jaw surgery. So coming to some of the general features that you would see, these are the outcome of certain studies that have been conducted. These patients will have an early convex profile, but gradually results in a straight profile. The soft tissue lip is long and the nose is less pronounced, but longer than normal. Arch width, which is an important finding, is markedly reduced as a consequence of palatal surgery. There is an increased incidence of posterior crossbite. The upper incisors usually are retrocline and they're locked within the confines of the lower incisors in linguoversion. Growth of cleft maxilla appears to be slow immediately after the primary surgery, but does not accelerate. So more studies indicate that patients with repaired CLP show reduced horizontal growth of the midface. So there is always a predominant tendency for vertical growth pattern. Rotation of the palatal plane in a clockwise direction. The concomitant findings could be a steep mandibular plane and tendency towards mandibular retrusion at times. Growth rates, this is an important thing. Growth rates do not differ significantly, but facial proportions could. So what is so important about the cleft maxillary hypoplasia or the cleft maxillary deficiency as a consequence of the pre-existing cleft deformity? They have the lack of normal cheek contour. There is a nasolabial imbalance, lack of upper skeletal support to the soft tissue. Though the soft tissue landmarks are perfectly matched, you may have a perfect lip and a perfect nose. This deficiency and deformity of the supporting skeletal tissue results in what we understand as cleft maxillary hypoplasia, or in simple terms, cleft maxilla. So the abnormal morphology in cleft patients are attributed to the intrinsic developmental deficiencies, functional distortions, and iatrogenic factors, where the surgical repair that has been carried out earlier is implicated as a major source for midface deficiency. You can observe or assess the cleft patients as early as possible when they are 5, 6, during a little earlier to the mixed dentition period, and come to a reasonable diagnosis whether this patient has a very evident cleft maxillary hypoplasia. So when you see these patients early, maybe at 6 years, 7 years, or maybe later on, what are the things that one could possibly do? You can do face mask as evident in this case, and you can see it does bring about a certain amount of changes, especially in terms of the maxillary hypoplasia, reducing the magnitude of the cleft maxillary hypoplasia. So it's tensile force that is applied on the circummaxillary suture by the appliance and bringing about changes. But the changes are limited to the teeth and the alveolar structures. Though it is quite effective, but of lately there is a lot of literature suggesting that this is not a very useful mode or a very certain mode of treating cleft maxillary hypoplasia at a young age, because most of what you have achieved will tend to relapse. And there is a problem of compliance, because these children will not be able to wear it all the time. So that being the case, an alternate therapy could be during young age to treat cleft maxillary hypoplasia is a bone-anchored maxillary protraction, where in the previous example that I showed, it is tooth-anchored. So this is bone-anchored. So you can use 4 plates, 2 at the zygomatic buttress region and 2 at the canine region of the chin. And then you can apply the elastic traction force, bringing about protraction of the maxilla. So it does bring about sagittal changes, and also thought to bring about soft tissue changes along with the underlying skeleton. So here is one example where it's our own patient who had undergone BAMP, otherwise called as bone-anchored maxillary protraction. You can see the changes. It's just now 4 to 5 months that the child is on therapy. You can see the changes that have occurred, particularly at the midface. Just an example to illustrate the role of BAMP. You can see the lip step has reduced to some extent. It's just a short follow period that we have. We don't have any long-term follow-up to claim anything very conclusive, but it is a useful mode of treating cleft maxillary hypoplasia during the growing period, and one of the methods coming under the category of growth modulation. So these are the X-rays to illustrate the changes that take place when you do a bone-anchored maxillary protraction. And you can see the teeth have also moved to some extent. Otherwise, if you are treating a full-blown cleft maxillary hypoplasia, what are the prerequisites? They should be minimum 16 years of age. They should have undergone alveolar bone grafting. Orthodontically, pre-surgical arch alignment and decompensation is mandatory in most of the cases. Of course, there are exceptions. You can do the treatment below 16 years of age if the retrusion is very severe and if there are other functional problems like airway, etc. And if the severity of the deformity has a severe psychological, causing a severe psychological imbalance as far as the growing child is concerned, then you can make an attempt to treat it earlier. So one of the ways of doing it is conventional orthognathic surgery vis-a-vis a LIFO-1 osteotomy. So here is, and what's the kind of osteotomy that is recommended? Instead of doing a traditional pterygomaxillary disjunction, an alternate method could be doing a third molar osteotomy. And it has definitive advantages of doing this. They are anatomically less hazardous, allows greater mobility of the segments, and more importantly, it has a larger vascular pedicle which can be maintained. And this was suggested none other than Trimble and Tiedemann way back in 1983. So this is what, of course, a lot of people do a traditional pterygomaxillary disjunction. Another useful advantage is posteriorly, you could place an interpositional bone graft in order to prevent the untoward relapse that is quite common with cleft maxillary hypoplasia. So here is an example of a LIFO-1 osteotomy, and this patient had mild maxillary hypoplasia with good complement of teeth. All that we did is advance the maxilla by around 6 to 7 millimeter, and that is the outcome. So single jaw surgery. The problem with conventional orthognathic surgery is the stability, and there are enough literature quoting the kind of relapse in terms of stability, 20 to 25% by Stolinga and even Polly JW and the others have reported a considerable amount of relapse. Of course, in modern times, the relapse rates could be brought down because of the type of fixation and also by maintaining a good post-operative occlusal stability, which could otherwise be an influencing factor contributing towards relapse. With modern methodology, the relapse rate could be considerably reduced or minimized. So here is one of our patients where we had done a bi-jaw surgery resulting in relapse. You could see that the patient has had relapse. That's the X-ray. So what are the contributing factors towards relapse in conventional orthognathic surgery? The extent of the maxillary deficiency, larger the moment, and if there is occlusal disharmony could be an important factor. Scarring from previous surgeries, particularly the alveolar bone grafting and mainly the palatal surgery could be the cause, and lack of adequate mobilization in your attempt to mobilize the maxilla. So these are some of the factors which could play an important role as far as relapse is concerned. Another modality of treatment is distraction, otherwise called as rigid external distractor. So here is an example of rigid external distractor. This patient required around more than 13 millimeter of maxillary distraction. That is done with the help of a rigid external distractor. And that is what we could achieve subsequently. And that is her wedding photographs. So what we have achieved in this particular patient and in all the other patients is by addressing the cleft maxillary hypoplasia, irrespective of the modality, whether it is conventional orthognathic surgery or distraction, you are reducing the stigma of the cleft. In the backdrop of a skeletal deformity, the stigma of the cleft is more pronounced. So if you do the skeletal correction, the stigma considerably reduces. So advantages of RAD is it is easy to install and remove. Vectors can be changed at any phase of the treatment. Disadvantages is compliance because you have to wear that big distractor and most of the patients would not tolerate with a frame over the on the head. And sometimes there could be a tendency for anterior open bite, which also can be managed by doing what is called a scalus molding with the help of elastics. Internal distractor is another modality that is used in order to overcome primarily the problem of compliance. So here is one example where the internal distractors were used. You can see the internal distractor in place, and then the maxilla is been mobilized with the help of these internal distractors, and that is the outcome. Okay, we moved it by around 9 to 10 millimeter in this case. Of course, this is one of my colleagues' case, it is not mine. So advantages of internal distractor compared to the external distractor, they're less conspicuous, okay? So your mobility is not curtailed by any means. It is easy to tolerate compared to the RAD. But there are disadvantages because they're difficult to install because of the complex anatomy of the maxilla, particularly in cleft patients. And the most important thing is because you have two distractors on either side, you have to maintain the parallelism. So that is one of the problems that you pose. In modern times, it's quite easy because you can have an STL model and determine the exact location where you or predetermine the exact location and establish the parallelism with the help of an STL model. It sometimes causes stretching of the buccal tissue because it occupies some space in the buccal corridors. So that can cause some amount of discomfort. The vector motion cannot be changed that easily compared to RAD. And it requires an additional surgery for removal. So those are some of the disadvantages. In general, the advantages of distraction osteogenesis, whether you use an RAD or an internal distraction, it has the ability, this is the most important thing, of generating new bone without the need for grafting. Okay, it can gradually lengthen the soft tissue because you are moving the entire skeleton incrementally. So it allows or gives you the leverage of some amount of expansion of soft tissues as well. And it can comparatively reduce the postoperative relapse, which is associated with conventional orthognathic surgery. So distraction osteogenesis does have a few advantages over conventional orthognathic surgery in selected cases. Not that for every case you should do distraction osteogenesis. So even in DO, it can cause relapse, especially in RED, because that is red, because the maxilla tends to pull forward. So when the distractors are removed, the tension accumulated as a consequence of the pulling forces, they tend to rebound, and that could cause a high relapse rate in RED compared to internal distractor, which actually transposes the maxilla forward. It doesn't pull the maxilla forward, it transposes gradually with the help of transverse screws as far as internal distractors are concerned. So RAD has some element of relapse. So this is an important article which would give you some insight into help you to distinguish between the relapse rate in conventional orthognathic surgery and distraction osteogenesis. So this is a meta-analysis. So from this, one can conclude that DO is preferred to conventional orthognathic surgery for younger cleft patients with more severe deformity or in severe cases. So you should limit distraction osteogenesis for cases which are severe in nature. Most of the other things could be addressed with the help of conventional orthognathic surgery. The other issues with cleft maxillary hypoplasia is the impact on speech. So when you advance the maxilla, these are some of the studies which says there's a 16% possibility of VPI or peripharyngeal incompetence. That is 16 to 23%. There are other studies by Nabil Saman et al., which says whether irrespective of DO or CO, it does not have any impact as far as the velopharyngeal mechanism is concerned. So you have two opposing literature at hand. So when you have this, what do you do? Does it mean there are a lot of people who would conveniently say that there is no hardcore evidence to suggest that advancement of the maxilla in cleft patients does not produce any detrimental effect on speech, as this particular article says. So you don't have to take this article as gospel truth. Instead, a safe way to approach this problem is, if there is an already compromised speech, or if the speech is mild to moderate, then you should treat advancing the maxilla with a certain degree of caution, because too much of advancement of the maxilla can have, you're not sure, can have a detrimental effect as far as speech is concerned. So this is not something that we need to ignore. It is like saying the presence of something did not necessarily mean the absence. Okay, so that being the case, speech is an important aspect as far as cleft maxillary hypoplasia is concerned, and it should not be ignored. That being the case, there is another modality of treatment for cleft maxillary hypoplasia, which is called as anterior maxillary distraction, which is much in vogue in the last decade or so. So it is with the help of a tooth-bone appliance based on a Hyrax screw, which the orthodontists otherwise use very extensively. But instead of using laterally, you're using it in an AP direction. So all that you need to do is an anterior maxillary osteotomy, or otherwise called as AMO, and then you place the distractor and do the distraction. This is useful particularly in patients who have an existing problem as far as their speech is concerned, or either the speech is compromised or the speech results are moderate, bordering to a compromised velopharyngeal mechanism. So here are some of the examples of where we have treated cleft maxillary hypoplasia by doing anterior maxillary distraction. Look at that. And another useful advantage of this is because it increases the perimeter of the arch and it gives more space for the tongue to occupy. And in some cases, if you analyze it, there is a definitive improvement in terms of articulation. So you're not disturbing the speech. You have the additional benefit of improving the articulation because you're improving the arch perimeter. So this is a diagrammatic illustration. And another important aspect or an important advantage of AMD is because when you have severe crowding, you can create space and accommodate the malposed teeth into that place, and that would help you to prevent the relapse or the space gained as a consequence of distraction. So there are multiple advantages because most of the cleft patients will have crowding, and crowding is one of the indication to do AMD. Compromised speech is one of the indication of doing AMD. So this is another diagrammatic representation of doing anterior maxillary distraction. So here is another patient who had the premaxilla excised during the primary repair, which some of the surgeons used to advocate earlier in order to facilitate the bilateral lip repair. So they would knock off the premaxilla. Of course, in recent times, less people do that, but there was a time when a lot of people used to advocate resection of the premaxilla. This is one such example. So what we did is we connected the bridge from one where the premaxilla was missing, and then we did an AMD, and that's the result that you would see. This is after doing AMD, and what you see there is a bridge connected. So look at the pre-operative negative overjet, and there is some amount of positive overjet post AMD, and that's a temporary bridge. So then subsequently we gave a more reliable or permanent fixed partial denture. Of course, are there problems with AMD? Yes. Very often you would get anterior open bite if you have not planned your vector properly. Of course, it can be managed with post-operative elastics or other and do callus molding. Then another problem is premolar occupying the space of the canine. Okay, periodontal ligament exposure, partial extrusion of the anchorage teeth, palatal fistula, tipping movement, etc. Can you do large movements because the Hyrax screw will allow around 9, effectively 8 to 9 millimeter? Yes. Now in this patient, we moved it by around 16 millimeters because we changed the appliance and put in a new appliance and did that extra movement that was required. So it is possible, may not be indicated all the time. The advantages is because it is distraction and you have new bone formation, which can act as a deterrent in terms of relapse. There can be some amount of wound contraction, which can cause some degree of relapse. And the most important aspect is the post-operative management of these patients, wherein you should be able to maintain the space with the help of your orthodontist, whatever space that you have, edentulous space that you have gained as a result of anterior maxillary distraction. Okay, these are the general things about distraction, about what is the percentage. It is 1:2, 2, potential to expand soft tissue and produce new bone. And the advantages are a stable, positive soft tissue change, which is under your control, because as you distract the anterior segment or the AOMO segment, you can look at the profile and decide what should be your endpoint. But it is prudent to over distract by 2 to 3 millimeter because there is likely to be some amount of relapse. It normalizes the nasolabial angle, gives some amount of projection of the upper lip or the upper lip prominence, improves nasal projection. These are the advantages of doing an AMD. It is cost effective, easy to fabricate, it's well tolerated by patients. Relapse, because this distraction is relatively less compared to conventional orthodontic surgery. That's what we could presume. Subtle improvement, as I mentioned earlier, in articular and overall acceptability of speech. Positive effect in terms of soft tissue changes, minimizes the deformity and the stigma of the cleft. However, this particular modality will require long-term multicentric studies to garner more conclusive evidence. However, it is an important tool or an important modality of treatment in terms of cleft maxillary hypoplasia. Another important aspect which generally people try to overlook when you address bilateral cleft maxillary hypoplasia is the soft tissue problem. And this is very peculiar to bilateral clefts. One should understand that the prolabial is devoid of muscle. And when you do the primary lip repair for a bilateral cleft, you bring in the muscle from the lateral segment. Having done so, the outcome is you have a difference in the circumference of the upper lip and the lower lip as denoted in this picture. So there is a circumferential difference, making the upper lip taut or tight. And in order to establish, that is inherent for any patient, they would want to establish a lip seal, which is involuntary. The lower lip gets everted. So there is a circumferential difference because you have brought the muscle from the lateral segment and made the lip tight. So it is not just enough in bilateral cleft patients to address the skeletal imbalance, but you need to also address the soft tissue imbalance, and particularly the circumferential imbalance of the upper and lower lip and the eversion of the lower lip, particularly contributing to that imbalance. Look at these patients. See, at a very young age, the deformity looks all the more severe. Skeletally, it is not so severe. It is contributed by the soft tissue phenomenon I just explained, making the deformity look all the more gross or grotesque. So here is an example where the patient's skeletal is reasonably normal, maybe less by 1 or 2 millimeter. Okay, as far as the occlusion is concerned, she's all right. So the analysis of this case is it is purely a soft tissue problem. So what we did is we did an Abbe flap and balanced the upper lip with the help of an Abbe flap. So what you normally do, it's a Robin Hood principle, borrow from the rich and give it to the poor. So there is a paucity of soft tissue as far as the upper lip is concerned. So we borrowed it from the lower lip and made the upper lip look a little more richer and aesthetically a little more pleasing. Look at the soft tissue. Look at the lip balance. So this is something that needs more attention. And you would also see the lip imbalance even after you have done the skeletal correction, which I will address it subsequently. So that is, of course, we also did a genioplasty on this patient because she had a steep mandibular plane. Now, as I mentioned earlier, any skeletal correction should be considered when the patient is at least minimum 16 years of age. But it did not be so true in all the cases. Now, this particular patient had severe midface hypoplasia. Apart from that, the child had two other functional problems, hyperlacrimation and OSA. So that being the case, we decided to address the issue much earlier than otherwise what the protocol permits. So he was around 10 years old. So what we did is a Lefort 3 osteotomy because we wanted to give adequate support to the orbit so that we can reduce the hyperlacrimation. This child had also undergone a tarsorrhaphy in order to support the eyeball. So this is the preoperative lateral ceph and the preoperative 3D CT. So we did a Lefort 3 osteotomy. That is one picture you can see exploring the floor of the orbit in order to proceed with the cut. And you can see the nasofrontal disjunction there in the second image. And we used an external distractor, okay, and a biplanar distractor. So we put a plate at the infraorbital rim and then a long plate in the just below the pyriform aperture. You can see it in the X-ray. So what we did is at the superior level, we distracted it. So it's a differential distraction. We distracted it by around 5 millimeter. And at the lower level, at the Lefort 1 level, we distracted it by around 27 to 28 millimeter. So that's him. So by doing this, what did we achieve? His snoring and OSA ceased after that, and his hyperlacrimation also has reduced to a considerable extent because the globes are well supported now. So that's him. You can see this picture. See, there is a marked reduction as far as hyperlacrimation is concerned. So that is the pre and post-operative CT. And his airway space, you can see, which is marked there, has considerably improved. That's why the OSA, we have been able to treat his problem of obstruction. That's it. Okay. As I mentioned earlier, there is always a tendency to camouflage this patient. Now, this is a patient who had undergone face mask therapy, also prolonged orthodontic treatment, and they have done the camouflage. Look at the occlusion, it looks reasonably okay. But look at the face, the hypoplasia still persists. This is another example. See, occlusally, they are okay, but there is a cleft maxillary hypoplasia which is glaring. So when that being the case, you know, if you try to re-prepare this patient orthodontically for surgery, could be an Herculean task since they have undergone a prolonged orthodontic treatment prior to that. Unlikely they will comply. So in such instances, here is a case, something similar to that, where they're dentally compensated. Okay, patient has a reasonably acceptable occlusion. So what we did is we did a clockwise rotation of the entire maxillomandibular complex in order to address the problem of cleft maxillary hypoplasia. So when you are doing it, there is no much change at the occlusal level of the maxilla, but superior to that, the maxilla will come forward. That's the whole premise of rotation. When you do a clockwise rotation, the maxilla away from the occlusal plane will tend to come forward, and the mandible away from the occlusal plane will tend to go backwards. And we also did a chin for this patient and subsequently a lip revision and rhinoplasty, and that's the outcome. So this is clockwise rotation of the maxillomandibular complex to achieve facial balance for a patient with cleft maxillary hypoplasia. That's it. We have not, there is no change, or there is no linear movement at all, or there is no sagittal movement at the occlusal level. Okay, that's the OPG and the lateral ceph. Here is another patient who had previously undergone AMD, and they have also done a chin procedure. So she still felt that she's a young girl, probably around 20, 21. She felt she looks old. And this is what we did. We did a clockwise rotation of the maxillomandibular complex with no changes as far as the occlusion is concerned. The occlusion remained as whatever that was existing. And we did a little bit of touch up for the nose because this patient has also previously undergone rhinoplasty. So that's the outcome of redoing the osteotomy. Of course, this patient has undergone AMD. So we did a LIFO 1 clockwise rotation of the maxilla and mandible. And we downgrafted the chin in this case because the chin was placed far too forward if you look at the preoperative picture. That is the outcome. So as far as the occlusion is concerned, there is no drastic change. I wouldn't say this is a good occlusion, but she was not willing to undergo any more orthodontic therapy. So we left it like that. So that is the pre and post-operative cephalometrics. Okay. Now, as we mentioned earlier, okay, there is a tendency for looking at cleft maxillary hypoplasia in isolation. So everybody thinks that, okay, you advance the maxilla, that is end of the story. But there is a problem of relapse, okay, which I mentioned earlier. There are also concerns of speech when you do more advancement of the maxilla. So, and there are also problems as concomitant problems with the mandible because you can have a steep mandibular plane. So all these things would necessitate the need for a bi-jaw surgery. So this was said way earlier. This is a very old article by Pauly and Figueroa, which said 2001 that you should do a bi-jaw surgery in terms. This is directly related to the problems of stability. But it is not just the stability. It is the stability to restrict too much movement of the maxilla. In terms of aesthetics, when you combine all these three, there is a need for bi-jaw surgeries in most of these patients, if not all. So when you do a bi-jaw surgery, it would reduce the other associated problems like deterioration of speech, stability, and in some cases, it would result in a better aesthetic outcome. For example, if the cranial base is short and you advance the maxilla more than 6-7 millimeters or 8 millimeters, there is always a possibility that the patient will end up with a bimaxillary profile. So that being the case, limit your maxillary movement, distribute your movement to address all these problems: aesthetics, stability, speech. So when I say bi-jaw surgery, it need not necessarily mean a Le Fort 1 osteotomy. Okay, here is this patient who had a maxillary deficiency. What we did is we did a anterior maxillary distraction and a genioplasty. So that's what we could achieve in terms of occlusion. And look at the pre and post-operative set. Okay, here is another patient, again bi-jaw surgery. When I say bi-jaw, maxilla, as far as maxilla is concerned, it need not necessarily be LFO1 osteotomy. It could be AMD and maybe some mandibular procedure. The simplest of procedure could be genioplasty. Okay. So this is a study we conducted on our own patients, okay, and looked at all the cephalograms that we had at our disposal. What did we notice? There is a steep mandibular plane, there is increase in the anterior facial height, and an increased mandibular divergence. So inferences, better aesthetic result can be obtained with AP surgery of both the jaws. Advancement genioplasty will reduce the vertical facial height, increase in the vertical facial height, thereby improving the facial balance. Okay, I would not go into what are the other findings. So let me skip that. So give you some kind of inputs as far as the need for a bi-jaw surgery. Now this patient had a severe maxillary deficiency. Okay, so what we did is we did AMD as far as the maxilla is concerned. Okay, because she had too much of crowding and she had some amount of already existing speech problem. So we didn't want to do LFO1 osteotomy. So we did an AMD, advanced it by around 7 to 8 millimeter. We also did a BSSO and a genioplasty. So it's a bi-jaw surgery and that is the outcome. Look at the profile. So that is after AMD and that's after BSSO. And of course, she had such bad teeth. So all that we could do and get away is by doing a prosthetic rehabilitation. Here is another case with a severe maxillary deformity with a negative overjet of more than 8 millimeter, 8 to 9 millimeter, severe crowding. So therefore, bi-jaw surgery is indicated for this patient because your quantum of movement in this particular patient will be around 10 to 11 millimeters. So would you do only the advancement of the maxilla? I leave it here. I would not do it. So what we did for this patient is we did an AMD first. And when we did the AMD, we got more space to accommodate to normalize the crowding. And subsequently, we did a bi-jaw. Okay. Here, I think the magnitude of movement was around 12 millimeter in this case. So we did AMD, we corrected the crowding, and then we did LFO1 advancement and BSSO. So that is the outcome. This is after AMD, the X-ray, and subsequently bi-jaw surgery. Okay, I would not dwell into the aspects of OSA and things like that. We'll leave it at that. Now, this is a patient where we bilateral cleft maxillary deformity. We did a bi-jaw surgery and look at the outcome. That is what I was trying to bring to your notice earlier. Because it's a cleft maxillary, bilateral cleft maxillary hypoplasia, the soft tissue imbalance erroneously gives you an impression of the presence of a maxillary or a skeletal imbalance. It is not so. It is purely a soft tissue phenomenon. Okay, this is after conventional orthognathic surgery, the occlusion. Look at it. We subsequently did an Abbey flap and look at the change in profile. What you see, the first picture is post orthognathic surgery and the second image is after doing an Abbey flap, which has tremendously improved the quality of the result and improved the facial balance. So that's a pre and post-operative X-ray. Here is another case to illustrate all that I have covered so far. Okay, here is this child with a severe secondary deformity reported to us when she was around 9 years of age with a huge palatal defect. You can see that. So what we did is we put a tongue flap to cover that defect. Okay, and look at the arch there. The arch is completely collapsed. Okay, expansion was done, arch expansion. Subsequently, we did an alveolar bone grafting, bilateral alveolar bone grafting. Subsequently, we did a external distraction for this patient, moved the maxilla by around 20 millimeters, and then there was some amount of relapse. Then we did a BSSO, but even after BSSO, you look at the lip aesthetics, the lower lip, there is a lip step there, giving an indication of the cleft, the stigma of the cleft. Okay, so to counter that, we also tried doing an AMD after that, thinking that the maxilla, if it goes still far, a little more in a sagittal direction, probably we will achieve the correction of that lip step. At that point, we didn't have this concept of the soft tissue imbalance. Okay, and subsequently, we did an Abbey flaponer, and that corrected the problem. Okay, this is the kind of orthodontics. So in your team, if you want to address the problems of cleft maxillary hyperplasia comprehensively, then you should have a good orthodontist to help you out, because they could be a great value addition. So this is what I would call as good orthodontics. Look at the arch expansion and look at the changes as far as this particular patient is concerned. That's her at 9 years. This is after AMD, after RAD. This is after BSSO. And the last picture is after we have done the Abbey flap. And that's her. So she's a very happy patient, and that's her. So from our own experience, this is what we would recommend. For a mild cleft maxillary hypoplasia with a well-defined arch, you can get away with LFO1 advancement. So when I say mild, it means somewhere between 4 to 6 millimeter. Mild CMH, if there is crowding, then you should do an AMD. If it's moderate CMH, above 5 to 6 millimeter, with a well-defined arch, then you can do LFO1, BSSO, plus minus genioplasty. If it is moderate CMH with crowding, then you can do an AMD plus BSSO and plus minus genioplasty. If it is a severe, and all these problems, okay, all the first 4 categories, if the speech is compromised, then don't do LFO1, opt for anterior maxillary distraction. But if it's a severe CMH with a negative overjet of more than 12 millimeter, then you could possibly think about LFO1 distraction plus minus BSSO and plus minus genioplasty. In case of bilateral cleft maxillary hypoplasia, as I mentioned earlier, Abbey flap could be an option in order to correct the deficit soft tissue. Thank you, ladies and gentlemen, for a patient listening. Okay, this is the same thing. So what is mild CMH? Less than 6 mm, moderate CMH greater than 7 mm, severe CMH more than 10 mm. Okay, these are my orthodontists who play an important role in all that I have mentioned during my talk. Thank you, ladies and gentlemen.
Thank you, sir. Thank you for the presentation. I will request now Dr. Parit, our craniofacial surgeon from Mumbai, to please take on the question, if any, for the speakers.
Good evening, Mustafa sir. How are you, sir?
I'm fine. Thank you.
Yeah. Sir, I have a question for you. Do you do always ABG before doing AMD, or is it possible to do AMD without doing bone grafting?
This is a very good question. I'll tell you why it is a good question. Earlier we used to do AMD indiscriminately. Okay. And from our own experience and errors, we have come to realize that if you cannot bring in a tooth there, subsequently the bone graft will disappear. So if you cannot bring in the tooth there for some reason, then the AMD is a wasteful procedure. So right now we would not do it at all cases where we cannot bring in a tooth. We will think about a prosthetic rehabilitation. But we would certainly opt for alveolar bone grafting, whether you're doing AMD or a Lefort 1 osteotomy, for a simple reason, because it establishes the continuity of the maxilla. Okay, it would prevent some amount of residual fistulae. So there are definite benefits, but we will always analyze the pros and cons, because if you can't bring in a tooth, that bone graft has failed.
Right. Thank you, sir. And sir, another question. I'm always a fan of your doing AB flap in bilateral cases, and that gives really wonderful results. But sometimes, sir, in unilateral case also you found lower lip is protruding, and even after skeletal correction. So how will you address that? You will use ABFLEX for unilateral cases as well, or you will do something else like lip augmentation with fat or some graft or something like that?
See, in unilateral cases, the lip eversion, lower lip eversion is not so significant, not so severe. Okay, but of course, in some cases, you would see the lower lip eversion, and that eversion gets corrected when you achieve some amount of skeletal balance. Okay, if you don't, even after skeletal correction, the lower lip is everting. If you notice that. You can do a Abe flap if the upper lip is severely scarred or compromised. If you have an upper lip which is reasonably good, then all that you need to do is, if the patient is complaining it as a major concern, you can just do a wedge excision and reduce the bulk of the lower lip. The eversion will get corrected. But you need to treat if the patient wants it, not otherwise. Just do a wedge incision and reduce the bulk. So that will correct the so-called positive lip step.
Right. Thank you, sir. Yeah.
That's a question.
Sure.
Yeah, I have a question to Dr. Najmi. Is he still there?
Yes, I'm here.
Yeah. You mentioned about the Haberman feeder.
Yes.
Yeah. Can you elaborate on that?
Well, Haberman feeder, it's the feeder has an extra reservoir on top of it, so that the parents can just, if the baby is not able to make neck positive pressure to suck on the nipple of the feeder, so the parents can, kind of push the reservoir, so they help the child to feed.
Oh, yes, thank you. And you mentioned about the distractor. When you put in the pins, you pinch the skin.
Yes.
So as to take care of the scar. How do you go about it?
I'll show it on my face. I don't know if you can see it.
Yeah,
if you
can see
it. If you put the two pins like this,
yeah,
while you distract, you will soften the pinch. Okay. So if you put it just like this, when you distract, you will scar the face. Yeah.
Thank you. I have a question, Professor Ase. Dr. Ase. Yeah.
Please.
You mean in hemifacial macrosomia?
Yeah.
If you were to tackle the auricle, two questions. What do you mean by augmenting the temporal bone?
Yeah. If we want to set implants that we can fix an epithesis, maybe you should check before you do that how thick the temporal bone is. Otherwise, you may get intracranially. Okay. I have seen such cases. Yeah, so be sure that the length of your implants is not beyond the inner surface.
And how do you manage the lower hairline?
The hairline.
Yeah.
In these cases, you think?
In a case of auricular reconstruction, if you're constructing the auricle,
yeah,
then the lower hairline on that side.
Yeah, well,
of that.
In fact, I have not seen a problem in this because, of course, you could just excise it and make a skin transplant.
Or would you try laser?
My experience with laser treatment of all types of displaced hair is not that good. So I would rather excise it.
Okay. Thank you. Thank you.
Yeah. Hello, Professor Rafe.
Hello.
Yeah, I have a question for you. When will you use in hemifacial microsomia case? When will you use costochondral graft, and when will you go for a temporomandibular joint replacement?
Excuse me, I
With
could not.
implants, yeah.
Once more, please. I did not understand.
Yeah. What are your criteria of using costochondral graft, and when will you use a temporomandibular joint replacement with implant?
I would use a costochondral graft.
Yeah.
Yeah.
Versus temporomandibular joint prosthesis.
Yeah. In these cases, I've never used so far. I've never used a prosthesis because I always suffice to use either a free rib graft or a vascularized transplant. But of course, it's an option. So far, I did not see the need to use a transplant. I've used transplants in many cases, usually in re-surgery of ankylosis cases, but not so far, not in a case of dysostosis orthomandibularis.
Thank you, Professor Rafe. And Professor Gosla, sir, I have a question for you.
Yes, please.
Sir, are you there?
Yeah, very much here.
Yeah, sir, I have a question that in case of facial cleft, what age you will go for a bony reconstruction?
See, all bony reconstruction is done at the later stage. Normally we try to do all bony reconstruction after 8 or 9 years once the dentition changes. That is, the deciduous dentition sheds off and the permanent dentition starts erupting. Then that is an ideal age to do a bone graft. Unless you are trying to do a orbital osteotomies for medialization, then the temporal areas where the defect is, then you can always do it even at very younger age. But anything in the phase, in the mid phase, if you want to do any bone surgery, you have to wait for the deciduous teeth to shed and then the permanent teeth to come down. They should not be in the line of your osteotomy or in the line of your augmentation of bone.
Right. And in case, sir, we need to graft any area, would you do at an early age, or you will follow same protocol, secondary bone grafting?
Always the bone surgery is done at later part of the life. The early stage of life, we try to do the soft tissue coverage corrections, and then we try to do the bony surgery at later part of the age.
Oh, okay, sir. Okay. Thank you very much, sir. Yeah.
A question for Dr. Mustafa.
Sure.
Yeah. What's your approach to VPI?
Pardon?
Velopharyngeal insufficiency.
Yeah.
What is your approach? Would you do a flap, superior placed, inferior placed?
Okay. Your question is, how would I address the problem of VPI?
Yeah.
Is that the question?
Yes.
Okay. First thing I would do is I would do a video fluoroscopy. Okay. And there is a way to calculate it is called, I can't get the name, the name of what the calculation is, what my speech therapist does.
Okay.
And then In most of the cases, I would do a Furlow's palatoplasty or a Furlow's Z-plasty. And in some cases where it is called as a closure ratio. Okay. If the closure ratio is compromised, then I would do an additional suspension pharyngoplasty. But most of the cases, I would get away doing a Furlow's.
Would you at any point put in a graft in the pharyngeal wall? If an older patient comes?
No, I haven't.
Okay. Thank you.
I have one question for Bhosla Reddy, sir.
Yes, please.
Can you hear me?
I can hear you, Chad.
Yeah. So if I'm not mistaken, you mentioned on early rhinoplasty. I think,
yeah.
Can you please elaborate? And then does these patients require a revision rhinoplasty later on? Like,
most of the time they may not need it, but if there are any minor corrections that needs to be done, they can be always corrected at later part. The primary rhinoplasty, what we do is basically for the septum. The septal reposition and septal correction, and to get the position of the nasal complex in relation to the lip or to the other structures. But if there is a need, definitely we had to do a secondary rhinoplasty at later part of the stage.
Okay, thank you, sir.
And Ghosla, can I readdress that question?
Yeah, sure, definitely, Mustafa.
Say it is like asking, would your lip require a revision? You know, some cases do require revision. However perfect you may do it. The same thing holds good for nose. You know, some of the noses may need some kind of revision at a later date. I understand the basis for that question, because from a lot of quarters this input comes. If you are going to do a revision nose at a later date, then why touch the nose? You know, it comes from that premise. Of course, lip or nose may need some kind of revision. Whether you should primarily address the problem, the answer is yes at this point of time. Thank you.
Thank you, sir.
Any more questions, Rashu?
There is no question from the audience. I think the speakers were quite clear in delivering their lectures. So,
or there are no audience.
no, there are plenty of audience. But I think it was quite dedicated to like advanced techniques today. So might be we are young audience.
In fact, this webinar was very learning for every one of us.
Right, exactly.
If there are no questions, I, on behalf of Isfaro, would like to thank all the esteemed speakers for the excellent talks. I also would like to thank Macrolab for their technical support, and of course the participants for making the webinar a success. And at this point, I would like to invite all of you for the next webinar on 7th of February on soft tissues of the face. Thank you so much.
Thank you very much indeed.
Bye.
I just wanted to say something to Dr. Rosse. I'm very glad to see him after 26 years. The last time I saw it was in...
just shows how old I am.
Well, we should keep in touch. We should email each other.
Yeah, we will.
We will.
Yeah, bye.
Thank you. Thank you all.
Thank you. Bye.
And have a good night.
Thank you, Dr. Lu. Thank you for joining.
Thank you, Dr. Rashu Mittal.
Thank you, everyone. Thank you for staying so late.
Thank you, Mohan.
Thank you. Bye-bye. Bye.
Bye.
Thank you, sir. Bye-bye. I'm ending the meeting, sir. Thank you.
Thank you. Bye-bye. Thank you. Bye, Mustafa.
Bye. Bye-bye.
Bye.
Thank you, Dr. Lu, for staying so late with us. It's almost midnight in Taiwan.
Yeah.
Thank you very much.
Thank you once again.
Thank you. Good night.
Good night.
Good night.